And for me, this is very important. You and Jana are podiatrists. Using a DIERS system, for me, actually, it doesn't mind whether you're a specialist, a podiatrist, any person that has sort of a medical background or has an idea about the human body, if they are interested, can learn to use the system and to analyze the data. Yeah? It's not that complicated. They are both active at Hox since a long time, and before they started using the system, the focus was here. It didn't matter what problem you had, you went out with an orthotic. Okay? They started changing. So it's a family business, name is Hox, and they now do orthoses, prosthesis, shoes, and they have a gait analysis research center. They have various locations, but they measure only at one location. That is the location where we initially installed the system. And they started doing the movement analysis with our motion lab in 2019. 90% referrals after 1 year were from the hospital, because the orthopedic department in the hospital realized we have to look at our patients in a different way. This is how the first installation looked. It wasn't the best looking installation, to be honest, but luckily we moved them a couple of months ago to a new location, and the motion lab, and this is actually lovely, this is their large room for patients, and the motion lab is behind glass, but they can just close the curtains. So if they only use the pressure plate, which I don't recommend, your first measurement should be holistic, but if for some reason you afterwards only use the pressure measurement, you can leave everything open. Okay? It's a, well, lovely place. I'm going to just discuss 2 cases with always same focus. So they received a young woman with loads of complaints. That's where it starts to be real funny whether it's ascending or descending, because she had problems all over the place. But she was at various doctors, and no one ever could really find the cause of the issue. You will see later on why. So she had physiotherapy, she had orthotics, she went to specialists, and she just kept on being in problems. When she was just looked at with the system, which is basically when she was looked at in a holistic way, they could see that she had an anterior pressure load and a load on the left leg. So that was not symmetrical. There was an increase in the knee flexion and the hip extension, significant pronation, especially on the right side. The trunk was what we call fairly normal. So we can see the shift to the front. You can see the knee. And by the way, this is what I loved. I think Marietta also already mentioned that. For me, visualization is motivation. If you looked at the patient I showed before, it's never nice if you have to say a person you have to lose weight. But if people see and you can explain why they have to do it, you motivate them to do something. Okay? So here you can also clearly see stance and legs. And as I said, fairly normal spine values, but once again, very important for me, be careful, because even if this is green, always have a look how many vertebrae are used by the body to get to that angle. The dynamic measurement often is a bit more interesting if you really want to see where a problem is located. You could see the hyperpronation, which you could already expect from the static measurement, but in dynamics it's even more. Drop medial arch, which often goes together, by the way. Overpressure on the first metatarsal, which is all related to each other. Premature heel lift, that's a very important one. Yeah? Asymmetric pelvic rotation, flattening of the lumbar lordosis, and asymmetrical spinal rotation. Although here, we had fairly normal results in the static. Yeah? Okay, these are the examples. Well, I'll just go back. Yep. So these are the examples. This is what the spine looked like. So you see, completely asymmetrical here. And at the end, you start writing a conclusion. A conclusion is only rarely just one point. I mean, you seldom see issues that are located just to one one issue in the body. So what we try to do more and more is to see where do we see at the moment, where do we see possible issues. And often it's 2 or 3 things. And what is a big, big difference? Possible shortening. This is not too interesting now. But it's the advice. We more and more try to give not just one advice, but 2 or 3 things. And in this case, the orthotic therapy was like the brace therapy with the previous patient, was a temporarily solution just to take loading off. Yeah? Physiotherapy is long-lasting, and the revision I show you, that was also temporarily. So the orthotic is just basically done to just take the pressure off literally from the system. The physiotherapy was a much, let's say, long-lasting solution, especially on the short muscles. Okay? And this brace was just used for a couple of weeks also just to learn the body to adapt in a different way. Yeah? So what we do here is, with this patient, is you just don't focus on one point, you just highlight what you think are the most important things and you combine them. Okay? Is that clear for everyone so far? Okay. Just for your information, when you see someone with short Achilles, with a fixed heel lift, I would always suggest to do at least one neurological test. That's something we have learned over the last 2 years. We often look at biomechanics and we forget, even with people from 40 to 50 years old, to have a quick check on neurology. Because we often only see a neurological problems 2 or 3 years after we would have been able to scan it. Okay? Second case. Load shift to the left leg, so mainly standing on the left leg. Major deviation at pelvic level, major deviation at spinal level, major hip extension. So everything is major here. Yeah, okay, I think you can see that. This is where we immediately think in terms of scoliosis, whether it's compensatoire or not. Difficult to say from one measurement, but you can see pelvis obliquity and you can see the C-spinal curvature. In this case, you still have your kyphosis and lordosis. Yeah? As long as you have your kyphosis and lordosis, you might expect a normal range of motion in the spine, especially when in the lordotic area it's flattened or it's way too high, you often see a hindered movement there. Okay, in the gait analysis, also here, hyperpronation and drop medial arch. As I mentioned before, they often go together. And we can see an end rotation higher up the chain. So in the knee and the hip. Yeah? Spine and pelvis, asymmetrical, which we can expect from the static measurement, and large deviations analog to the static measurement. These are the measurements. I'm not going to focus too much on measurements. We have done that for 3 days. We learned over the time that this is wrong as a conclusion for a patient. What we've done here is we basically listed everything we think this might be a cause of this, this might be a cause. We learned that if you communicate with a patient, try to stick to 2 or 3. You can always look later on whether you work on the other ones, because this is just way too much information and it's completely impossible to work on everything together. So what we've learned is, if you look at this conclusion, and you go, and I hope I have that to the recommendations, you see loads of recommendations here. This is impossible for a patient. These are all fine recommendations, but what we do now is we would highlight the 2 or 3 ones where we would like to focus on, because it's completely impossible to focus on everything together. And if you highlight, what we've seen is, if you work on the 2 or 3 most important factors, you often see that the other ones might not be necessary anymore. Yeah? Because as soon as you would have been directly into the cause of the problem, you start seeing a better movement or a better functionality overall anyway. It's not always that easy. We have had patients where our first approach did not work well, which is logical. I think that's logical. Now I go one step further. If we look at rehabilitation of people, rehabilitation, we seem to think that each person is the same. So if you had knee surgery, that's your rehabilitation trajectory, which is fully insane. Because if you would measure every 6 weeks, you might be able to fine-tune rehabilitation based on the person that is in front of you. So I just want to say in general, if you have this system, even if you don't have the system, if you have a holistical approach, just look at the full picture to start with and go from there instead of focusing on what that patient is complaining from.